Great to be here. Thanks so much for the invitation, opportunity to be with you all. Great. I've just been listening in a little bit. Just fabulous. So thank you so much for all that you're doing. David's crediting me with being an inspiration, but I think David is an inspiration to me, and I think to so many people around the world in this realm. He's been such a leader in leading this great charge with this international research. Absolutely fantastic. I'm privileged to be here with you all. I'm going to share my screen so you can hopefully all see my slides. Okay, you can see those.
Looks good, John.
Fantastic. Thank you for the feedback. Yeah. I was asked to talk about mechanisms of recovery. I've spent a lot of time in this area looking and thinking about mechanisms. I've also been reflecting more recently just on where we've come in 50 years. 50 years ago was the declaration of the war on drugs under Nixon in this country, in the United States. And we've learned a lot, not just, in terms of the about the failure of the war on drugs in terms of its punitive approach, but also, importantly, about the nature of addiction and how people change and recover from addiction. So just think about what we've learned in 50 years since the birth of NIAAA, the National Institute of Alcohol Abuse and Alcoholism, the National Institute of Drug Abuse, which funds 90% of the world's research on addiction. And we've learned a ton about causes of addiction, its etiology, the impact on the brain, the epidemiology, the pathways to recovery, which of course we're involved with here in this project, the clinical course, what happens when people get symptoms and what happens to them over time, and treatment. But I think there's a paradigm shift. All these paradigm shifts have happened over this last 50 years, but there's an important one going on right now. And this is why we are all here, of course, to understand what is it, what are the factors, not just that initiate change, but sustain change over time. How do people get and then stay well and stay in stable remission? We have learned that the clinical course, of course, of substance use disorder tends to be long, particularly in the severe cases, the severe end of the spectrum, the kind of people that we see in specialty treatment settings. It can take up to 8 years after people seek help to get 1 year of full sustained remission. And it can take a further 4 to 5 years of continuing remission before the risk of reinstatement of the disorder in the next year is no greater than the general population. So that tells you that this is an illness that is susceptible to relapse even after people achieve that enormous achievement of that 1 year, first year of recovery, as has already been pointed out in terms of what do we see there, David, about a 30% relapse rate after that first year. So it's still unstable in those early years of remission. Where we've done a good job in the last 50 years, I would say, if we can use the metaphor of a burning building, we have recognized well that there is an emergency, that the building's on fire, there's a crisis, we need to put it out. We've really focused on stabilizing people and providing acute care services, generally for 4 to 12 weeks. That's where we focused our, necessarily because it's been very important for detoxification, stabilization, and medical treatment. But what we have failed to do is really provide the building materials after the fire is out, is providing people with the building materials that they can actually start to rebuild, refit that building, what we call recovery capital, or sometimes are called the social determinants of health, and also granting building permits. This is very important when you think about the failure of people's inability to be able to get a loan, to get a job because of prior criminal convictions related to drug use. So they're denied even a building permit to get started, as well as the building resources. And this is why there's been a new emphasis on creating more of these resources, what we call recovery capital. I think what's really interesting and instructive, if you look at the National Institute of Drug Abuse, what they now consider to be comprehensive drug addiction treatment. Take a look at this. I think in the center, we would think, oh, these are the things that normally we would associate with providing good quality treatment. But look around the edge, things like family services, vocational services for job training, for housing, for legal services, all these other things which we wouldn't normally associate with drug treatment, quote unquote, are now incorporated in this comprehensive drug treatment program, according to NIDA. Now, when we think about mobilizing change, of course, treatment is intended to mobilize the mechanisms of therapeutic change. And there are a number of other recovery support services that have emerged over the last 80 to 90 years. And most of these have come about really in the last 20 years. Again, from people who recognize a need that wasn't met by clinical services themselves, but the kind of things that they felt that they needed to, again, to mobilize and sustain behavior change. And some of these are mutual help organizations. 12-Step, of course, is the oldest and the largest, but there are others: Smart Recovery, LifeRing, Women for Sobriety, and so on. There are peer-based recovery support services like recovery coaching, recovery residences, clinical models of long-term recovery management, recovery community centers, which I'll talk a little bit about today, and recovery supports in educational settings, such as collegiate recovery programs and recovery high schools. So all of these services have emerged and grown, not just in the United States, but are growing all over the country. What I'm going to talk about today is what we've learned from the mechanisms research on behavior change, how people change. And I'm going to use a particular example, one that's been convenient, and because it's very large and we have good data and good big studies on it, which is Alcoholics Anonymous. So I'm going to talk you through a little bit about what we've learned and then what we can extrapolate and infer based on the research that we've done and others have done on understanding the mechanisms of this ubiquitous indigenous recovery support service, peer-based recovery support service known as Alcoholics Anonymous, which is, of course, in the UK, in many other countries around the world. Now, when we think about levels of mechanisms, of course, there are multiple levels of mechanisms that one can look at, right? It just depends on what you're studying. You know, if you're studying a policy intervention versus a cellular intervention, you know, you're going to look at different kinds of mechanisms. What I'm going to talk you through with regards to AA is mostly social and psychological mechanisms, but I will allude to some potential biological mechanisms that could be looked at, because we know that everything that a human being does is mediated through the brain. So everything that we do behaviorally, every thought that we have is a biochemical process. And it can be changed from the inside out through a medication, for example, and from the outside in through choices about what we do and what is provided to us in the environments in which we live. So when you think about recovery support services, including treatment, generally there's a goal to enhance, to help people achieve remission and enhance their quality of life. When we think about the mechanisms through which that occurs, we think about stabilizing people medically, biomedically, and then providing the resources, the recovery capital, that can then help them get a foothold in recovery. And of course, that recovery capital can then induce other changes inside our heads, in our body, in our social networks, and in our psychology. And it's through those changes that, of course, help us to achieve and sustain remission and enhance quality of life. Now, there is, when we think about interventions, whether that's housing, whether that is peer support or other mutual help, sometimes there's a theory that's explicated, that's detailed, where we map out maybe some boxes and some arrows, and we say, yes, this should lead to that, that should lead to that, and that should, just as I've done there, and lead to an ultimate outcome. Oftentimes, of course, that's not the case. It's implicit. And sometimes the theories, the data, don't always map onto the theory, okay? So, and this is a point I want to make today, but it's very helpful to start with the theory and see how well the data fit the theory. This is an old saying, what's the difference between theory and practice? In theory, there is no difference between theory and practice, but in practice, there is, right? So in theory, there is no difference, but really there is always a difference between theory and practice, because our data never quite fit the model that we have. And we call these, in statistics, you always look at the fit indices. How well does the data fit the model that you've explicated? Again, as George Box, the statistician, said, all models are wrong, some are useful, right? All models are wrong, some are useful. And so what I'm going to hopefully present is some useful models, particularly to do with mutual help. And again, as I mentioned, we've got a kind of a luxury of having this very large, ubiquitous recovery support resource in AA and other 12-step organizations. Millions of people attend every single year. These are free, indigenous, ubiquitous recovery support services. I think about these as the closest thing that we have in public health to a free lunch. They're freely available 24/7, 365 days a year, and they work. We just published a Cochrane review demonstrating clearly for the first time, I think, the value of these resources in the community. And when we use clinical interventions to link patients to them, we can not only improve outcomes, but substantially reduce healthcare costs. Now, when you think about the actual way that AA is purported to work, in 12-step groups like AA, is purported to work through a spiritual awakening. That's what AA itself says in its literature, right? Is that people have a spiritual awakening through that process of a spiritual awakening. That's how they achieve recovery. It's explicated in the 12th step. But of course, there's a lot other things going on in AA. The peer support, the fellowship, the meetings, the sponsorship, all of the things that go on, all of this rich, dense social activity and exchange goes on in AA. So what do we know from a scientific standpoint? Is it spirituality that conveys the benefits of Alcoholics Anonymous, for example? Or is it other things, or a multitude of things? Well, there's been a lot of research that's been done, dozens and dozens of well-conducted mechanism studies, particularly looking at how AA confers benefit over time. What we did in this study is that we looked at multiple mechanisms together to see what was the relative importance of these multiple mechanisms through which AA worked. So in this study, we looked at 6 different mechanisms that have been shown to confer the benefit of Alcoholics Anonymous on outcomes. There were 6 different independent mechanisms here that were looked at together. And we asked the question, to what degree does participation in AA mobilize these different mechanisms, which included self-efficacy, 2 types of self-efficacy. One was related to negative affect. In other words, how confident are you in your ability to not drink while experiencing negative affect, boredom, depression, anxiety? The other one was another type of self-efficacy called social self-efficacy, which was how confident are you in your ability to not drink when facing a high-risk social situation. We also looked at spiritual religious practices that were measured in relation to AA. Does AA mobilize those spiritual practices, and does that account for benefits in terms of remission status? We looked at depression symptoms. Does AA work by reducing depression? We also looked at 2 types of social network factors. Does AA work by increasing abstainers and people in recovery into your network? And does it also simultaneously work by removing bad influences or negative influences, people who are heavy drinkers, drug users, out of your network? Does it work by both of those processes? And then we looked at the relationship between changes in those intermediate indices and then the relationship to alcohol frequency of use and intensity of use in the subsequent period. You can see this is a properly temporally lagged study. So it's properly time sequence, so you can make causal inferences. On the left-hand side, you can see we were controlling for all the confounding variables, including other treatment and their baseline measures of those same variables, so we could look at the independent effect of AA over time. Now, some very interesting results here. Let me just orient you real quick to this. On the left-hand side, we have one outcome, which is abstinence, number of days abstinent. On the right-hand side, the DDD in the column, it's intensity of drinking. And in the row, the top row, is patients who are more severely addicted to alcohol. They were inpatients before they came into the study, and then they were followed up as outpatients. In the row below, there are outpatients, so they were less severe. They didn't need inpatient detoxification before coming into the study. Now look at these 6 different mechanisms. So this is the proportion, right, of the mediated effect. In other words, to what degree, what's the relative importance of those 6 mediators in terms of AA participation over time? Now we know in this study, I was found in many other studies, that going to AA you had better outcomes, right? Substantially better outcomes, particularly regarding continuous sobriety. But what's interesting is that the way that AA helped people differed across these 6 different dimensions. Okay, spirituality, if you look in the top, let's look at the bottom left-hand one for a start off. So you have the less severe patients in terms of abstinence. You can see those 3 large sectors. AA worked in the purple sector by boosting people's confidence in their ability to cope with high-risk social situations. It also helped people stay abstinent by boosting their social networks, adding people to their social network and recovering people and removing negative influences. And among the less severe patients, as you can see, the spiritual segment, which is just that green segment there, was very small. It was, in fact, non-significant. Now look at the top, the more severe patients at the top. Again, similar mechanisms, but slightly different. Among the more severe patients, you can see a much bigger segment that's attributable to spirituality. So different mechanisms depending on this clinical characteristic of severity. Here's another example. In this case, we were comparing men and women. The question here is, do men and women differ in the way that AA helps them achieve sobriety in AA? We found in this study that men and women benefited the same. They had derived the same degree of benefit. But what's really striking here is the different mechanisms that were explaining the positive benefit of participation in AA between men and women. Look on the right-hand side here. Let's take the top segment in the right-hand side. This is intensity of drinking. So you can think of this as relapse risk. For women attending AA, again, they derived the same degree of benefit. But the way that AA helped women was by boosting their confidence to cope with negative affect. That was the strongest predictor of relapse for women, was negative affect. Now look down below for men, that blue segment. That wasn't even hardly present for men. Conversely, look what is present for men. The biggest factor for men, the way that AA helped men stay in abstinent and prevented relapse, was by boosting their ability to cope with high-risk social situations. So the same intervention, but producing very different, the same outcome, but doing it, achieving it through very different mechanisms. For women, it was largely about negative affect. You see that depression segment too up here. It was helping them cope with negative affect, and that was the chief way that AA helped them stay in remission. For men, it wasn't that way at all. It was through boosting their ability to cope with high-risk social situations. Here's just one more example. This is with young people. So these are young adults compared to older adults. Same kind of setup here. But they were looking at 18 to 29-year-olds versus people who are 30 plus. We had the luxury of having a large sample here, so we could look at these things. Now look on the left-hand side. You can see the dark gray bar here, dark gray portion of the pie on the left-hand side here. Again, different mechanisms here depending on age. For young adults, the way that AA was helping young adults stay in recovery was by helping them drop negative influences out of their social network. That was also, if you look at the top where the older adults are on the left-hand side, you can see that dark gray segment, about half the effect. That was about half of as much of the effect as it was for young adults. So for young adults, it's about maybe AA was helping them drop those negative influences. But what was interesting, it did not help them adopt new people in their recovery circles the way that people who are going to AA who are older. Now, it may be because there's just fewer young people in AA for them to adopt those younger people into their social network. So here's an interesting point, is that the same intervention produces benefits that differ in both their nature and magnitude in these 3 cases, between more severely addicted individuals and less severely addicted individuals, for those who are men and women, and for young and older adults. So what's interesting about, again, theory and practice is that despite the underlying theories regarding how exactly a particular recovery support service is supposed to work, in this case AA, the way that it actually conveys benefit is multifactorial, and it's not the same for everybody, even though the outcomes can be the same. So another way of saying this is that, yes, an intervention may work differently for different people, or people use interventions differently depending on their particular needs, their individual life context, and their characteristics, and their stage of recovery, because we know recovery is dynamic. We've already heard that from the findings this morning. So very interesting. It's very similar to what the psychotherapy literature has found, is that rather than our cognitive behavioral intervention or our motivational interviewing intervention, of course, they have strong theories underlying them. But what patients tend to be doing is they are listening in and choosing the things that are available in the repertoire of available goods that are available, therapeutic goods, and picking and choosing the ones that have most relevance and most salience to them to help them cope with the kinds of things that they need. And we're finding this, and we found this through our work with looking at AA. Now, these are the empirically supported mechanisms of behavior change through which we have found that AA confers benefit. It confers benefit through all these ways simultaneously. These are all individually occurring to varying degrees across time, including spirituality. But spirituality is not a major factor. It's actually working, particularly among those who are more severely addicted. It tends to confer a benefit in terms of keeping people sober. But what's really interesting here is what we have found is that AA, in this case AA, a recovery support service, very ubiquitous, is working by mobilizing the same kinds of therapeutic mechanisms which are mobilized by formal treatment, but is able to do so in the communities in which people live over the long term for free. So here's the good news for public health, is that here we have a highly ubiquitous indigenous recovery support resource that is able to mobilize these same therapeutic factors that are mobilized by more expensive formal treatment, but can do so over time for free. And this is just a kind of a side note that what we are finding from the data, from the actual empirical work, is that the fit of the data fits better with the later publications from Alcoholics Anonymous, particularly the book Living Sober, which talks about the social, affective, and cognitive behavioral changes that go on as a function of the peer support in AA, than it is with the kind of more spiritually focused origin of AA, which I think is interesting, because it's giving support both to the origin in terms of spirituality, but expanding the bandwidth of the therapeutic mechanisms which are operating and are being stimulated and mobilized by AA. So this is just another quick example where we're able to look at mechanisms. Here's a different kind of service. This is what we call recovery community centers, or recovery cafes, they're sometimes called in other parts of the United States. But these are hubs in the community which are designed to, again, mobilize people to change in positive ways by providing recovery capital. And interesting here, when you think about what's happening, is participation in these recovery centers is mobilizing both social support, as one would expect, but importantly, mobilizing access to recovery capital, which in turn increases self-esteem and quality of life, decreases psychological distress, and thereby increases the chances of ongoing remission. I'll just end by just alluding to briefly some of the other things where I think we could go. We've learned a lot psychosocially from the research of the mechanisms of behavior change, particularly in AA, as I mentioned. I think we're going to learn a lot more over time as we understand how these interventions convey effects. And again, AA is just one example, okay? But it's a peer-based example that is widely used. And I think probably what we'll find is that there are some common mechanisms which were mobilized by all of these kind of entities. But there are some that are specific, which can also, for some people, convey a more specific benefit that is not engendered or mobilized by other interventions. But when we think about addiction and its effects, of course, on the brain, and it's talked about as a disease that affects the brain, of course, and we know the neurocircuits are affected and the structures of the brain are affected dramatically, depending on how much one is exposed. So the question is, when we look at the neuroscience of recovery capital, can friends, jobs, housing, change the brain in similar ways. We have these major pathways to stress. We know social buffering. We know from a biological perspective how important our social interactions are in terms of changing our brain and reducing stress, right? We always turn to our friends, to our family when we're stressed out. We talk about it with others. And of course, this is a major thrust of any mutual help organization or peer support entity. We know that when we, someone we can talk to, confide in, cheer us on, give us some support, it actually mitigates stress. And there's a biological mechanism for that. And we're learning more about those. Also, in terms of reward capacity. In the dopamine reward pathway in the brain, this is dramatically downregulated as a function of exposure to alcohol and other drugs. When people abstain, the brain starts to recalibrate that dopamine pathway, and those dopamine receptors increase. And we know that social support and social recovery capital and other recovery capital is correlated with increasing capacity to experience reward. It upregulates those aspects of reward. And this is just one study that was done with primates, which demonstrated that when you manipulate the social environment and you provide monkeys with access to recovery capital, their dopamine receptor system increases, and those who showed increases in that dopamine receptors actually had a lower propensity to relapse to cocaine because they were all provided with cocaine and were all hooked on cocaine. Interesting, the social environment, access to resources, can actually promote changes, not just psychosocially, but under the hood, and increase the capacity to experience normal levels of reward as well as decrease stress. So I think there's lots of things to be learned regarding humans and how human beings respond to these mechanisms as well as psychosocially. So mechanisms help us understand more precisely what factors are adaptive to recovery-related change in some. Mechanisms occur at many different levels. The best level, I think, is the one that best fits the question you're trying to answer, whether it's a policy question, a recovery question, or a clinical question. Explicating theory and measuring and testing mechanisms and their relative importance has a reciprocal benefit, as we've shown with AA, that can help understand the nature and the active ingredients and mobilizers of therapeutic change attributable to particular interventions. And similar mechanisms, what so-called common factors, are likely mobilized by a variety of different interventions and support services. Some may be specific, as I mentioned, to particular interventions like spirituality in AA. That's not going to be present, say, in smart recovery. But a number of these mechanisms are likely to be mobilized. So here's the thing, is that people can choose and select interventions that are likely to be appealing to them, but are likely to result in mobilizing similar therapeutic indices that can help them get and stay in remission.